All right. Well, look, others will join, and we're also always very mindful that we're joining from around the world, and some people have to come in and out. So we are recording, uh, but we'll get started because we actually have a lot of stories to tell and content to cover tonight, which is so exciting. So, thank you all very much for coming. This is actually our 16th Community of Practice meeting on the road to 2030. We started in 2021 and we've been meeting every quarter, and we've been going for about 4.5 years. It's amazing how time flies. Hard to believe June is almost over. So before we start, in Australia, we always take a moment to acknowledge the traditional owners of the lands that we live and work on. I'm very fortunate to live and work on the lands of the Wallumattagal people of the Eora Nation here in Sydney and pay my respects to their elders past and present. Also acknowledge all the different lands that you all join in from the 6 WHO regions around the world. And this is a lovely photo of the CAH community in Vietnam, and we'll have the pleasure of having Dr. Joseph Zung attend a meeting with us in Brisbane later this year and talk about the incredible work that they do for children with CAH and other chronic conditions later this year. But you're all doing amazing work and really want to thank everyone for what they're achieving. An overview of today's meeting. I'll just start with a bit of housekeeping and share the agenda for today, tonight. A bit of a refresher on Mates for Kids, who, what, where, how, whatever. A few updates on grants and upcoming events. Housekeeping, if we can all stay on mute. We're recording and that will go up onto YouTube, and we'll share the recording in the minutes so that everyone sorry, not in the minutes, in the next email to the Mates for Kids Network. We encourage everyone to sign up to the CAP. If you need help with that, please reach out. And we encourage you all to connect in the chat. We've already sort of said Diane and Esther really need to be in touch. Feel free to share your email addresses, connect. We're a community of practice. We're here to work and connect and network with one another. We have the 3 objectives: access to medicines, strengthening CAH communities, and scaling newborn screening. If you've got a special interest, you can put it in, but if you're just interested in everything, that's okay too. I'll be just very quick with my few updates, but then we have the team from Ethiopia joining and giving a story about the work they're doing. Esther, I don't know if you wouldn't mind reaching out to Dr. Sewajan and just checking that he's able to join. The team in Chad will share a bit of an update on the WHO resolution that we're doing. The team from Chad will be dialing in there at a conference, I think, in France, but they're going to step out and come and join us and give an update on the work that they're doing in Chad. We'll share information. It's International Neonatal Screening Day on the 28th of June. So we've got some resources and links and information we can all share with one another and help one another. Dr. Esther's going to give us an update from Uganda on the brilliant work they're doing. And some of the team from the Asia Pacific were hoping to join, but we're going to talk about newborn screening, that we've got some exciting updates. Oh, there's the team from Chad dialing in now. Hi, Celine, lovely to see you. And Diane, we might throw to you as well, perhaps in this CAH International updates, just on some newborn screening things, if you would like to give an update as well, because we know you have to go to bed. And then the team from Colombia, they might be awake by the time we get to them. They're up really bright and early, and they'll give us some updates on the incredible work they're doing in Colombia. So just a really quick refresh. Mates for Kids, we're an international coalition of like-minded individuals and organisations, and we're committed to reducing the preventable mortality associated with CAH by 30% by 2030. We believe this work is important and contributes to delivering on the SDGs, notably SDGs 3.2 and 3.4. We shared our first briefing document with WHO in 2022, and we started our work together in 2021. And we've been going from strength to strength since then. We focus on three things: access to medicines, strengthening CAH communities, using the 5 pillars of CLAN, and scaling newborn screening. And we celebrate 28th of June where we can. We come from the 6 WHO regions of the world, but we always have the CAH community as a whole at the centre. We bring as many different types of stakeholders together as mates for kids within this community of practice. We all have different skills and talents that we bring to the table, but we're all focused on the same objective of reducing mortality. A bit of a timeline. We started, as I said, 21, 22. We launched the briefing paper. We have activity reports, 18-month reports on our first bits of time. Our next activity report will be launching at the Science Summit in September of this year. And we've really not got that long to go. We've got 1, 2, 3, 4 years to go. It's crazy. So we've got a lot of work to do, people. We really leverage events where we can. We have some indicators. We've got some exciting work happening with that we'll talk about at Science Summit this year. And our grants are really important, and we've got plans to give grants to 40 countries by 2030, which brings us to our round 8 grant recipients. Huge congratulations to the teams in Ethiopia and Chad. They're both presenting today, which is exciting, and they're doing really amazing things with the CAH communities in their countries. Round 9, we were going to close around the time of the World Health Assembly, but it all got a bit hectic and busy, and we've extended that date to the 28th of August. So if you know of any CAH communities who'd like to do some work and would like some modest funding, but you can do a lot with a little, then please ask them to get in touch. I won't talk so much about Neonatal Screening Day now. We can talk about that later, but just a couple of brief updates on some upcoming events before I hand over to the next speaker. The High Level Political Forum for 2026. The theme is transformative, equitable, innovative, and coordinated actions for the 2030 Agenda for Sustainable Development, and it's the SDGs for a Sustainable Future for All. That'll be held in July in New York. CLAN had an oral statement and a written statement accepted. We will share the written statement with the report on the July event. There are 36 countries giving voluntary national reviews. So this is where the countries come and say how they're progressing on the SDGs. We noted Tonga was there. So we really framed our written statement and our oral statement around newborn screening, noting the really exciting news that Tonga and New Zealand are collaborating on some newborn screening. Diane might be able to share a bit more about that, but we really focused our statements on access to medicines and newborn screening in particular. As I said, that happens next month, and we'll share reports after that. We were also very excited. Each year, the Science Summit is held on the sides of the UN General Assembly in New York. There's also it's also being held in Nigeria, I think it is as well. But we will be doing a virtual side event. The theme is From Boundaries to Breakthroughs, and that definitely explains the work that we all do together. And our side event is titled Uniting Childhood NCD Communities to Improve Access to Essential Medicines and Technologies. And this will really all focus on work that we're doing together around a proposed resolution on access to medicines and technologies for 2027 at the World Health Assembly next year. But I'll talk more about that later. So I will stop sharing now, and they were the main updates that I wanted to give before handing over the floor. Dr. Sewajan was going to be our first speaker from Ethiopia, but I can't see. Esther, have you been able to get in touch with him? I'm not sure if he's the administrator, but what we can do. Esther, are you there?
Yes, I have not been able to get in touch with him yet.
No problem. Thank you. I'll email him. Diane?
Peter, I've just emailed you a really exciting update,
Oh,
which
yes.
is a document that it's in fact embargoed until they announce it on Newborn Screening Day from the World Health Organization about supporting initiatives for all different kinds of newborn screening in low and middle income countries.
Great. Thank you, Diane. Please feel free to put it in the chat as well, Diane. It hasn't come through to my email yet, but I'll,
It's a quite big file.
oh, okay. Okay. We'll send it out in the Mates for Kids email then. Thank you.
Sit on it for a day or two because it's embargoed sort of right now. But
Oh, gotcha. Okay. Gotcha.
it's a really exciting development from them. And as you know, they've only recently been thinking about blood spots as a part of birth defect screening. So we're
Yeah.
really very happy about that.
Yeah, that's very great. And they actually just released a news release on the 23rd of June. So I'll get a link to that and pop that. I've got that here as well. So I'll pop that in the chat. I agree with you. It's definitely clear that WHO is a lot more focused on newborn screening. And maybe we can all collectively pat ourselves on the back for poking the
I'm sure
bear.
they're, they've suddenly realised that blood spots and biochemical problems are as much birth defects as cleft lip and palate or pricky hips.
That's great. That's really wonderful. That's great news. So, onwards and upwards. Okay. Well, speaking of champions who are looking at newborn screening in their region, Celine and Dr. Jarry, is it okay if we hand to you first, and bring you a little bit further up the agenda? And I feel like you'll be happy with this as well. Um, can we hand over to you to share your updates with everyone?
Yeah, yeah, absolutely. Jerry's here as well. So unfortunately, we're not in the same room because he got a visa issue, but we're both able to connect. So the point of our little talk today is to give you some updates on the donation that the CAH community received from Clan in Chad. So by Jerry, and I'm just speaking on his behalf because of the language issue, but he's as we're here as well to answer your question if needed. Chad got connected to Clan earlier this year, and I must say that we got a pretty human quite rapidly because we received the first medication in, I think it was at the end of May. So the CH community is composed of 16 children, now unfortunately only 15 after one baby died. There is only one pediatric endocrinologist in the country who was recently trained, and the cohort is really increasing because most of the patients are under the age of one, because he diagnosed them since he graduated. So we received the medication really rapidly, and everything went really smoothly thanks to Glam and all the things that was coordinated perfectly. The medication that all of the medics were after that shown to the director of the hospital and to some representative of the ministry, because they were also invited to the first meeting of the CH community. So they were really impressed to be able to receive such medication, for which jury really acknowledged that it was life-saving medication. And the head of so the director of the hospital is a pediatric surgeon, so quite well understand what CH is and its challenges. So it really initiated the discussions about how could we make hydrocortisone and fluorocortisone available in the country, because just to let you know, there's just one pharmacy in the entire country that has access to hydrocortisone, and that there is no access to fluorocortisone at all. Um, so the fact that we received the medication really started and initiated the discussion about how could we make this medication affordable, how could maybe the hospital purchase them. But then jury is initiated discussion with the Ministry of Health in order to receive to include, sorry, the hydrocortisone, hydrocortisone into the national essential list for medicine. So these are ongoing discussions, sorry, for the year to come and 2027. So after he presented the medicine to all of the administrators of the hospital, they started distributing the medication to the community. Um, One thing is that because there is kind of a lack of trust with the pharmacy and a lack of knowledge of how to use the medication, it was not possible at the time to coordinate with the local pharmacy in order to distribute the medication. So Jerry organized a one-on-one meeting with every patient so that he could deliver 1 month's supply of hydrocortisone to the patient and extend that to 2 or 3 months comes from far away. So that is the situation as it is now because um, he's really afraid that the pharmacy will actually sell the medication to their own purpose. So that's a bit the update for the community in Chad. So the Jerry has been really by the comments of the parents because as I was mentioning, one little girl just died a couple of weeks before we received the medication. And with this CH community being newly created, it really moved and shaped the entire community. And the words that they expressed when they received the medication were really moving, and their gratitude was immense. To receive such medication because it is so unaffordable for them that they now realize it will actually save their children. So that's a bit an update from our part. So I don't know if you have a question from Jerry is here.
Well, we really want
and I can translate.
We want to congratulate you all because incredibly, you held the first, Dr. Jari organized the first CAH club meeting as well. Are you able to share a couple of insights about the club meeting and what happened at the club meeting? And also, we understand that Dr. Jari is now also talking with the Ministry of Health about newborn screening. And I know that he's met with the ISNS team, Jim Bonham and Diane as well. And now we're starting to have conversations about newborn screening in Chad. Can you share updates on those other two aspects of the work that you guys are doing as well?
Yeah, sure. So the CH community, the first meeting was held in April, and it was so there was 16 family, and it was a really beautiful moment. I was able to share some slides from Plan showing other community in the world. And what really stood out there were other people living the same things that are there at the moment, and it really get them out of their loneliness, I would say. And it was a really emotional moment for everyone because a psychologist was hired for the meeting thanks to the grant. And it really opened up the discussion and opened up their feeling about what it is like to live uh, with the condition. And the community was created after that. They're chatting repeatedly. I can see that on a WhatsApp group. So they're starting really to bound. And met one of the father of the community really took the leadership of that, and being the president of the community, they really it was really spontaneous parents who stood up to be part of the board of the community, um, which really gives hope for the future. And the next CH meeting is already like being planned in the next coming weeks. And the parents were really relieved to find that support in one another, I would say. Related regarding the newborn screening program, I'm sorry, Diane, that I didn't have really time to come back to you about that lately because I have been so much focused on the WHO resolution that it took kind of all my time. But we having this plan of a pilot study for at least congenital hyperthyroidism and sickle cell disease in Chad because uh, the incidence of sickle cell disease is supposed to be 3% in Chad, so it's a huge contributor to neonatal and under five mortality. So we are having some discussion at the moment. The lab guy, he's really invested as well, but we're coming from really far ahead because the concept of newborn screening is something not implemented in people's mind in the country. So it's a lot to think about and a lot of logistics, considering that moms uh, are getting out of the hospital quite early after birth. So it comes with a lot of challenges, but I can assure you that there are lots of motivation to go ahead with that, and we'll keep the discussion going.
Celine, that's
But thank
amazing.
you.
And I absolutely agree that the infrastructure is the hard part. The laboratory is not hard. The hard part is collecting the samples and getting them to the lab, and then the follow-up and the treatment and finding the babies. So that's the hard part.
But we'll get there. I know we are because Jerry is here. Is really motivated, and I know. Um,
Of course you
I
will.
mean, with all of the things that he did for the CH community, it really showed the Ministry of Health that he was motivated and that he had reliable projects to move forward, and they're really on board, which is a really positive sign to get funding and to get the health authority on board with that.
And once you have the program going with those less time critical conditions, it will be very simple to add CAH.
Absolutely. It's we get starting somewhere to get a bit further after that.
You're starting in a good place.
Yeah. Well, thank you so much, and thank you, Clan, because the CH community is so grateful for everything that you've been doing. And I'm now at the French meeting of the Pacific Endocrinology Society, and we have a couple of colleagues from Switzerland and Africa, and I was discussing the project I have with Jury, and now they want to go on board with that as well. So I'm going to motivate new people into starting these new projects for their local community.
Wonderful. Please tell them about the community grants that are available, Celine.
Absolutely.
Absolutely. I think we have a CAH community member from Chad on the line. Is that Habdamu Ayin? Would they like to say something? Welcome, welcome, welcome.
Not sure.
Hello, everyone.
Hello. Would you like to introduce yourself? Oh, are you from Ethiopia or?
I'm from Ethiopia, one of the parents.
Welcome, welcome.
Yeah,
Oh, well, thank you. My apologies. I wasn't sure if you were from Chad, but so Celine, thank you so much for your excellent presentation. Please give Dr.
Thank
Jowry
you.
our warmest regards. He is a superhero. I don't know how he does it. He's the only pediatric endocrinologist in the whole country. He is looking after children with type 1 diabetes, all these other endocrine conditions. We think you're a hero, Dr. Jowry. So there he is, the man himself. Did he want to say anything at all?
Est-ce que tu veux dire quelque chose, Jory?
Thank you. Ah non, merci. En tout cas, c'est un plaisir et je les remercie pour tout. Et puis bon, pour tout ce que tu as dit, donc merci.
Paola can speak French. She can understand.
he he's just saying that he thank you again for everything that you've done, and it's a privilege for him to be here.
Oh, well, we definitely feel like we're the ones who are privileged. Lovely. Okay. Well, thank you. Congratulations to Chad. Now we have some more superstars to hear from. So, without further ado, I'd like to hand over to the team from Ethiopia, Dr. Sewajan and the community member from Ethiopia. So, please let us know all about what you're doing, particularly around access to medicines, but community development, everything. We'd love to hear your story. Thanks, Dr. Sewajan.
Okay, thank you very much. Can you hear me? Great, thank you, thank you. Thank you for giving us this opportunity. Maybe let me give you some background information about activities in CH in Ethiopia. So now we have around 40 cases of CH were being seen in two major hospitals, and where one of it I'm working. And those of among 40, 20 of them are expected to be the salt users who require fluorocortisol. And previously, we those who can't afford access to the fluorocortisol, uh, either they will die, or some of the families who are relatives abroad, they have to get this medicine from their family. Still, these families were struggling because our prescription was not accepted there. So we have having sometimes even they have to bargain with hospitals there so that they can have this prescription and they get access to fluorocortisol. Otherwise, the rest were dying. But recently, because there is an increased demand, now we are able to get this through also black market, but where the availability was not consistent and it was very expensive. Most of our families cannot afford this. And now, thanks to the support from clan, now we are able to get these donations and now we're having around 8 families are access to this medicine. We are using check score to have this medicine for these families, and our plan is to increase this to 50 to 75% of the communities with CH through using this check score. And before that, the diagnosis of CH in Ethiopia is also challenging because now we're using clinical criteria for the diagnosis, and for those who can afford, we are sending the 17-hydroxyprogesterone abroad, and they are able to diagnose. Otherwise, we are making it diagnosis by clinically. So now we're also planning to organize CH communities in Ethiopia to have a better awareness about CH, and also we are also planning to advocacy for about CH in Ethiopia. And after that, we are also planning to have access to people in Ministry of Health so that the importation of the drug will be easy. As you know, after we have a donation from Clan, even importing was a very challenging one. Even though this drug is among the essential drug lists, but people in the ministry also we have the Drug and Medicine Control Authority. Those people will have some questions when we're having that challenge, but now finally we are able to get the medicine now. Now we are getting for the families. That's what we are doing so far, and so we have through the grant from Clan. So we are planning to have to organize families with CH in Ethiopia so that they can have also have better organized, and also they can demand their right about the access of this medicine, this important medicine, and that's what we are doing. Maybe Haptamu is one of the leader for CH in Ethiopia. Maybe he's with me if so he can also say something about this. Thank you very much.
Okay. Hello, everyone.
Hello, welcome, welcome. We're so excited to hear from you. Please share your story. It's wonderful. I have a son with CAH, and you're a parent with CAH. It's very exciting to connect. So please share with us.
Okay. Thank you. My name is Haftam Wayena. I'm a parent of a daughter from Ethiopia. Now she is 1 year and 2 months old. And I also represent the Ethiopian CAH parent community. Thank you, Dr. Sawagen, and thank you, Plan, for inviting me to share our story and Ethiopian CAH achievements. When my daughter was born, we didn't know what was happening. We had no idea what CAH is. Actually, I am not health worker. I am not health professional, and I am simply a parent. We felt scared, confused, alone. There was no local support group, no one to guide us, but gradually, with help of Dr. Swagen, we found our way. Every day is a balance, giving medicine on time, watching for crisis, managing social life. It is exhausting, but we do it out of love. Honestly, the diagnosis was hard. The daily medicine schedule is hard, but the hardest part is it is not giving the medicine on time every day, but it is getting the access to medicine. This is the hardest part in my story. We give medicine with love on time every day. That part is easy, but finding the medicine, that is the work. But I want to share some good news as a parent representative. I have seen how far we have come. We now have small parent group, regular checkups, data awareness, WhatsApp group. Thanks to Dr. Sagan and others who has been a pillar for us. Just recently, with plan support and Dr. Sagan's tireless work, fluorocortisone finally delivered to Ethiopia. We have access to this medicine. This was not easy, I understand. It took many ups and downs, but it happened because of Dr. Sagan's, his friends, Dr. Getans, and others who knocked on every door to make it happen. On behalf of all Ethiopian CAH families, I want to say thank you very much. Thank you. This delivery means our children can breathe a little easier. We are so grateful. But this is just one delivery. We need this to become a routine, not an occasional donation. But the reality is we still face huge gaps. Most families outside Addis Ababa have no access to specialists, specifically pediatric endocrinologists. The biggest gap, the one that terrifies us most, is the medicine supply. Fluorocortisone are not always available. When they are, the price is unaffordable. So my ask today is simple. Please help us build a reliable supply, not occasional donation, not one-off shipments. We need a system. Please create a system to get the access so that I open that cabinet. I know, not hope that the medicine will be there. Support us in creating a sustainable supply chain. Support training for more health workers out of Addis Ababa. Thank you for listening. My daughter and all Ethiopian CAH children are counting on you to work together. I am happy to take patients or connect with anyone. Thank you very much.
Wow. I feel a little bit emotional. That is a wonderful speech. And I actually could see that you were reading that. And I wonder if you might email that speech, because we are doing some work on access to medicines. And I think that your speech needs to be at the front of our
Great.
work. So please share your speech. That was very powerful. Please know that we are committed to long-term supplies. Clan has committed to a 3-year supply to Ethiopia. Where we can't afford enough for everyone, we are grateful Dr. Sewagen uses the check scorecard to make sure that the families in greatest need have the access. We want every child to survive. But we will be working with your Ministry of Health, the government in your country, and governments all around the world on the WHO resolution. And I think this is a very good time to talk about the WHO resolution. But I am mindful, Diane, that you need to go to bed. And I wonder if you want to talk about newborn screening before we talk about the resolution, or would you like to speak now? But Tamu, thank you so much. We have heard you. We have heard you, and you are part of this community, and we're not letting you go. So we all work together, and we are very committed to long-term solutions.
Thank you for the offer, Kate, but I'm absolutely fine sitting listening.
Okay.
I am teared up by what I've heard from Ethiopia, and I wonder if we could talk later and offline about how we could get technology for them to be able to do 17 OHP measurements.
Thank you, Diane. Oh my gosh. And this is why this is so powerful. Yes, yes, and yes. So yes. And
the relatively cheap technology that they're using for newborn screening could be very well used for diagnosis of patients and also for monitoring. So if we could,
yes,
we could talk offline about costs and funding opportunities.
Thank you, Diane. That's a definite yes. And Celine, you are at a big meeting with lots of other African countries there. So if you want to talk to them about it and talk to Dr. Jari about it as well, that would be wonderful. So Dr. Sewagen, we will
100%.
Yeah, we will link you in, Dr. Sewagen, with Diane. That's 17 OHP. Look how powerful Habtamu's speech already making change. So thank you.
I can't imagine from where I'm sitting how difficult it is.
Yes, agreed. Okay, well, this is the perfect time to talk about the work we are all doing together on the proposed WHO resolution. So I think that we will talk about that now. So is that screen okay? Can you see that? Okay. Is that okay? Thumbs
That's
up.
better.
Yep, you can see that. Great.
Yeah,
So
that's better.
this year in February, we came together at the United Nations Commission for Social Development side event. It was online, and we had experts from children living with asthma, diabetes, childhood cancer, sickle cell disease, and congenital adrenal hyperplasia all come together to talk about access to medicines and technologies. And everyone agreed that access to medicines is the #1 challenge for families. And we heard that very powerfully from Habtamu tonight. And also everyone agreed that access to newborn screening is a real challenge. And it's very exciting, as Diane mentioned earlier, that we're now seeing WHO speaking a lot more about access to newborn screening as well. And at that meeting in February, Carmen Oste, the co-chair of Mates for Kids and the mother of a survivor of childhood cancer, a very powerful advocate, she said that this is a resolution-worthy issue. And we also had representatives from WHO there, and they told us that 2027 was a very good year to advocate around access to medicines, because 2027 is the 50th anniversary of the WHO's essential medicines list for adults. It is the 20th anniversary of the essential medicines list for children. And in September next year, we have the 3rd United Nations high-level meeting on universal health coverage. So we all decided and agreed that we would work together towards a resolution. What is a resolution? Well, a WHO resolution can be a very powerful instrument. It can inform policy by different governments around the world because all of our governments come together in Geneva each year in May for the World Health Assembly, and they agree on health priorities. They agree on actions that they will all take together on health. And we have seen many resolutions in the past, resolutions on screening and birth defects, resolutions to do with diabetes, non-communicable diseases, and so forth. But we haven't ever seen a resolution on access to medicines for children with ongoing health needs, with chronic health conditions, with NCDs. So we feel that this is a real gap. There are lots of challenges. The SDGs currently don't focus on children with NCDs. The WHO essential medicines list is very good, and drugs like hydrocortisone and fludrocortisone are on the EMLC, the medicines list for children. CLAN and others worked hard to get them on that list in 2008. But as we can see with hearing from Chad and Ethiopia today, getting medicines on the essential medicines list is not enough. We need implementation of the essential medicines list. So Celine is on the line here. She has been an absolute superstar, helping us to draft a version of what the resolution needs to cover. We have shared that resolution with all the childhood NCD communities. We have had ongoing conversations with all of the childhood NCD communities. People have been giving us feedback into this draft resolution on how we can improve it and strengthen it. We have had 2 drafts already. We're going to be releasing the 3rd draft at the end of July. We are also pulling together a paper which has the evidence base going to the literature to say why this is an important resolution to have. And that will include case studies from cancer, sickle cell disease, type 1 diabetes, rheumatic heart disease, congenital adrenal hyperplasia. Habtamu's story will be in there. So we will have all of these case studies from all of the different childhood NCD communities, and we will be asking all of our allies to go and talk to their Ministry of Health and ask their government to support this resolution, because it's not us who can make this resolution happen, it's our governments, our ministries of health who can make this happen. So we will be sharing more information. We have a working group meeting next month, and we have the next draft with the supporting document, the next draft of the resolution. We'll have some social media tiles. We'll have a lot of resources for everyone so that you can go and have these conversations with your own Ministry of Health about this. But we believe very much that this is what is needed for us to rapidly scale change for all of the communities that we're working with. Celine, do you want to have anything else to say? Because you've been such a big part of this journey. Would you like to add anything to that?
I just want to say that it's the momentum with all of the NCD community is really, really important. We can see all of the meetings that you had at the WHO Assembly, and that everyone's pretty much aligned that this needs to happen, and it is our job to make it happen. So we're going to keep doing with everything we started so far, and we're not going to give up so that no child is left behind.
Yeah. Thank you, Celine. You are a wonderful writer. If anyone needs something important written, Celine's your woman. So, and we are really dealing with the biggest organizations in childhood NCDs in the world across asthma, diabetes, childhood cancer, sickle cell disease, epilepsy, you name it. So when we ask for case studies, we've had response from everyone within 24, 48 hours. People say yes, like it's phenomenal, the engagement that we're having. So we feel very encouraged. Clan will be speaking with the Australian government again. We've already had a couple of conversations with them, and we will do our best to. The Australian government couldn't commit to anything before World Health Assembly 2026 because they were too busy. That's okay. That's understandable. 2027, we'll be starting conversations about next year, and we would ask you all to talk to your ministries of health. So in our next Mates for Kids newsletter email, we will share the resources with you all for you to take to your governments and have the conversation. We need at least 5 governments to come to support the resolution for it to go ahead at the World Health Assembly next year in Geneva. So, and Diane, we might even have another in-person World Health Assembly event next year as well, if all goes to plan. So, any questions on the resolution at all? No. Great. Okay, lovely. We are now, thank you to Ethiopia and Chad for your updates. We are now up to newborn screening, and just would acknowledge that we are, let me see if I can get out of here, that we have International Neonatal Screening Day coming up on the 28th of June. I will share my screen here for this, for Newborn Screening Day, and we'll do that. So hopefully, is that sharing now? Okay. Yep. So International Neonatal Screening Day is a movement started by the organisations Diane works with, such as the International Society of Neonatal Screening and other big players in the newborn screening space. It's celebrated on the 28th of June each year. That's when Dr. Guthrie Robert Guthrie first used, it's his birthday, and he was the one that started using the filter paper for PKU and hypothyroidism, and that we still use today. So we are developing some social media resources, and we will share those with everybody by email, and you're all welcome to use them or copy and paste the content and do it for yourself. The other resources we have are our child-friendly rights flyers, and I love to hear Dr. Sewagen talking about helping the CAH community fight for their rights. And so this is the role of these rights flyers. We have newborn screening flyers talking about the rights of children to newborn screening. We also have CAH child-friendly rights flyers, which talk about the rights of children living with CAH to treatment. We are in the process of finalising rights flyers for congenital hypothyroidism and sickle cell disease as well. But we will include links to these resources in the resource pack that we share with everybody, so that you can all use them as well. So that's enough for me. The next person I'm going to hand over to is Dr. Esther from Uganda, because they are doing some incredible work in the field of newborn screening. Esther, can I hand over to you? Esther is one of the directors of Clan Child Health Africa, and she's amazing. So over to you, Esther.
Thank you, Kate. And I'm just going to share. I think you have to give me permission to share my slides.
Yep, it should be right to go now.
Great. Okay. So I'm going to apologize. I'm not going to put my video on because it usually tends to disrupt most of the connectivity and makes it difficult for me to present. So apologies. Maybe I'll just let those who've not seen me before have a chance to see me and know who is speaking. Yes. Hello.
Hello. Thanks, Dr. Esther.
Yes. So I'm here just really to talk about the work that we are doing in regards to building health worker capacity for really early identification of children who have CAH here in Uganda. So this being a study, I'm just going to let you know why and how we decided to do some of what we are doing. The background of this is we know that CAH is a serious genetic condition, and because it causes severe adrenal crisis and early death. However, here at home in Uganda, the awareness about the condition really remains low, especially amongst our health workers. And this has really resulted in delayed diagnosis for the girls. But when it comes to the boys in particular, we do not even have boys with CAH who have been diagnosed in our clinic. So really that is a big gap that exists. And so we believe that strengthening the capacity of the health workers in identifying these children is actually quite a critical step for us in being able to improve diagnosis. So when you look at this, I'm trying to show what the situation is like in one of our in the only national referral hospital in the country. And it's the one that has the one endocrinology clinic that is available to the public. The rest are private facilities. So the children with CAH are about 19%. So those are unconfirmed. But there's 51% of children with DSDs in the clinic have never really been classified as CAH or not, or because there's no access to the diagnostic. So tests, investigations, they're unable to get. So they are really just being managed for symptoms, and we don't have a diagnosis that's been assigned to them. And so the purpose of this study is to see that we bridge the knowledge and the practice gap that really exists among our health workers, but we also see that it supports the Uganda strategy for improving child survival. If we're going to improve deaths from things like adrenal crisis, then we can improve actually survival of the children here. And we see that this will provide really for us a basis for advocating for newborn screening, because the only currently approved newborn screening that's happening is the sickle cell disease, and that is happening countrywide, and it's recent. It's not something that's been there for long. But us to be able to actually include other illnesses, this really provides the basis for that. And it's a study, so there are research questions that we are trying to answer. We asked for the current gaps that exist. Yes, we believe that they exist, but what are the actual gaps that exist in awareness and in management? And then want to do a training for our health workers to improve on their knowledge and then their practice. But we also ask, is the training model that we are proposing actually feasible? Will it be accepted by the health workers? And can we scale it beyond the one facility that we are working with now in the country, but also within Africa region as well? So our objective was to collaboratively, meaning work with the health workers and the endocrinologists, to be able to design and test the acceptability, feasibility, and then the scalability of a strengthening intervention for our health workers in a tertiary hospital. We have done a feasibility study with the pre and post evaluation, and the study sites have been two. That is, Kawempe is a referral hospital for mothers and children. So most of the deliveries in the country that are public are referred to this particular facility. And then when it comes to the other facility, which is Molago National Referral, that is the site that has the endocrinology clinic, the only free endocrinology clinic in the country. And so we are hoping that we can access the parents there to conduct the interviews. We've had 60 health workers. We used 60 health workers because this being a feasibility study, and because this work has not really been done in Africa before, we did not have studies that we could use to calculate our sample size. So we worked with what is recommended for feasibility studies, and that is how we decided on working with 60 health workers. We've done 5 interviews with the hospital administrators at that particular hospital, and we are yet to do the interviews with the parents to collect their health needs assessment really, and see where the issues are when it comes to the parent side. We've had, we used structured questionnaires and interview guides to collect our data. And this is really what it has looked like. We had an inception meeting at the referral hospital. So we were there to introduce the project to the health workers, but also to the administration as well. Then we conducted baseline interviews with the health workers only. That happened in March and mid-April, alongside the qualitative interviews. We have also completed the training for the health workers. This happened end of April into May. And we are yet to do, so we have two pending activities. That's the health needs assessment survey for the parents, but also the follow-up interviews with the health workers, which we hope to do in this coming month. So what do our baseline findings look like? We've not yet had a chance to analyze. The analysis has not been completed for the results. So what I'm presenting is basically the preliminary findings from the baseline survey. We have, when we looked at most of the health workers who participated were nursing officers. So nursing officers most times are female health workers, and that explains why majority of our, health people who participated were actually female, and there were 73.3% of the number of health workers we had. And most were aged between 31 to 40, so they're pretty young people that participated. When we looked at their previous training on CAH prior to this, we realized that 45% of them actually reported that they've not had any kind of training on CAH. And among those who had had training, so the 55%, other 55%, majority had had a pre-service education. So part of their training before they qualified for their service, that's where they had heard about CAH. A few had attended a bit of workshops on CAH and had a bit of case discussions that happened at the hospital, probably. We're not sure. And when we asked them if they had actually had the chance to see a child with CAH, so majority had not had any training on CAH, but then we saw that some of them, majority of them had actually seen a child with CAH before, whether it was during their duty, not that they handled the child themselves, but at least they were told, oh, this child has CAH, and they had a chance to see a child. But we still see that a big number, 40%, have never encountered CAH in their clinical practice. When we looked at their knowledge, the questions that we're asking around knowledge, capacity, about access to diagnostic tests, this is one of the things that really came out. When we asked about 17 OHP, majority, 70%, did not know whether this test was actually available. And I know that this is a broad say, but a good number of them even told us they do not know what 17-OH, so did not even have knowledge that there's a test called 17-OHP that is needed. And then among those who knew that the test, the 30%, reported that the service was not available at their hospital. And mind you, this is a referral hospital for mothers and babies, but there's no availability of 17-OHP at this particular facility. We definitely have ongoing analysis, and we've sort of generated some scoring that we are going to use to assess knowledge practices and their confidence in managing these things. So the knowledge questions that we asked are around definition of CAH, clinical presentation, what the diagnosis is like, their knowledge on emergency management and referral of the children who have this CAH. We have developed a scoring because we asked open-ended questions, and we need to sort of tease these out so that we can standardize them a little bit. But of course, some of the responses that we definitely received included things like, I do not know that disease, I have never heard about it, or most of them described more the external appearance, so more it's ambiguous genitalia, but there was limited knowledge on the biochemistry of how this happens and how to actually manage the children. And the questions that we asked around practice, included questions on being able to recognize the suspected CAH, what to do for initial management, how to investigate the children, and documentation really, and follow-up plus referral. And then when we came down to confidence, we were asking them questions around their confidence in being able to recognize the children, confidence in examining for actual ambiguous genitalia, initiating initial management for these children. And I hope that I'll be able to come back and share what comes out of this knowledge scores, especially at baseline, but also when we compare it with the follow-up. Preliminary, what really came out was most of them recognized, ambiguous genitalia as the presenting feature. A few were able to actually tease out the salt wasting symptoms of vomiting, dehydration, and shock. There were really, really few. And then when it came to knowledge on 17 OHP, extremely, very, very, very few. And even when we asked the open-ended questions and tried to just, get if they know about cortisol deficiency, like what happens, we had almost very, very few. And the ones who actually did give us a response, especially in this last section, were the pediatricians who had a bit of knowledge around the cortisol deficiency and all. So basing on what we got from the preliminary findings, we identified these gaps that existed. The formal training was limited. We realized that adrenal crisis management was limited. Awareness on investigations that need to be done was limited. They were uncertain on, what should I do? How do I refer the patient? Do I wait? Do I refer them later? All these things really were coming out from the preliminary findings. And so basing on what we got from the preliminary findings, went on to do the training. And we were trained about 65 health workers. Some of them attended, some of them were study participants, some were not study participants. In-person trainings were 43. We had initially aimed to have only in-person trainings, but we realized that what did not work, and we didn't have all the health workers that we had targeted to train participate. So we had to add the component of virtual training to our method of delivery. And on average, the trainings lasted about 90 minutes per session. We had set out to have them run for 1 hour, but we realized that the 1 hour was not working. So we had to adjust to 90 minutes to allow questions and answers from the participants and address all their concerns as much as possible. So our training basically had focus on the situation within Africa, but also in Uganda specifically, because during our previous engagements with the health workers, they always asked, what does CAH look like in Uganda? And is this a problem that needs to be solved? So we're able to address that. We looked at the definition and classification, signs and symptoms, and then emphasized the first conversations that these health workers have at birth and being able to actually counsel the families, because we realized this was another area that was challenging for them. What do I do when I'm faced with a child with CAH? So we had focus on the first conversations at birth, and then the referral pathway for these children. So when you have a child with CAH, refer to the pediatrician within the facility, and we also have the pediatricians refer to the pediatric endocrinologist, and we made that clear. And we shared a bit of resources with them. I'm going to talk about them a little bit later. And some of the insights that came out of the training, and this is just a bit of really what we saw, there was a lot more. The participants were really, really receptive of the sessions. They were grateful that they had an actual opportunity to learn about CAH, and they literally, I think we had this at every training session. They asked, are you going to extend this training to other health workers in the country? Because I feel like more people need to hear about this. And one of the nurses one of the midwives told us, thank you for this training. I've seen a child with ambiguous genitalia before. We said she was female, but when they went on to do a scan, realized the child had no female reproductive organs. And she said, I understand that was a mistake that we made. So you need to actually give this training to more of my colleagues. So she acknowledged that her and her colleagues were actually having a similar challenge and that needed to be addressed. And so as part of the training, we developed a brochure for our nurses and our midwives, given that their level of education is not very advanced, and we had to make something that is very simple and something that they can put in the delivery room. So if you see a child at birth, before you wrap the baby, are you sure about the genitalia or not? If you're not sure, refer. So we had to come up with simple information like this that is in their delivery rooms, at immunization clinics, within the well child follow-up visits, all those, to be able to tease out and pick out these children and then refer them. And then for the pediatricians and the obstetricians, we shared the guidelines for management of CAH, which were developed by the Pediatric Endocrine Society of Kenya. And we shared these for them to use for managing adrenal crisis before they can actually refer the children to the endocrinologist. So thank you, and I'm happy to answer any questions and any concerns.
Wow, absolutely brilliant, Esther. Congratulations. And how exciting to have the health professionals asking for more. That doesn't always happen when you give training. Does anyone have any questions for Esther at all? Just want to acknowledge this is work that they've been doing with their grant. I can't remember what grant round you were, Esther, but this is really groundbreaking. And the poster that you've developed really prompted the sickle cell screening people to reach out and want to connect and talk about screening. And huge congratulations, Esther. Thank you so much for the work you're doing. Any other questions or comments? Anything else you'd like to say, Esther?
I do not have anything else to say for now, really. But I would also like Diane, if the same that was mentioned for Ethiopia could be mentioned for us here back in Uganda, because this gap is very big and it exists and it's glaring. So
Right.
I would really be happy if we could have 17 OHP, provided for our people back at home here.
Great. Well, without any further ado, Diane, we're going to hand over to you now. Thank you, Esther, for your excellent presentation. I'd like to introduce Diane. She's a newborn screening guru from New Zealand, and I'm putting her on the spot because she's not formally on our agenda. But I do have a wonderful update from Dr. Natasha Heather, who is Diane's colleague in New Zealand. And colleagues in New Zealand have been working with their peers in Tonga. And Dr. Natasha has shared an update about the great work they're doing in Tonga to scale newborn screening. And they have also shared a wonderful poster that they've developed, and I'm just going to put that in the chat. I've got a copy of that poster here. It's a wonderful example of locally developed resources to speak to community in culturally appropriate ways. I hadn't seen this before tonight. Dr. Natasha shared it and asked us to share it with you all. So, Diane, we'd love to hear any words of wisdom you have about newborn screening, not just for CAH, but how do we connect in with the broader newborn screening agenda? We also acknowledge International Neonatal Screening Day on 28th of June. Do you have any advice for us all on the best ways to celebrate that, or to talk with our governments about newborn screening? Over to you, Diane.
I think it needs champions, and sometimes champions come from within the community, and sometimes they are healthcare professionals. So success in Tonga goes absolutely to Dr. George Aho, who is a pediatrician who could see the need. I think maybe you know that there's quite a high incidence of CAH in Tonga, Samoa, Fiji. And so he particularly wanted CAH screening, but understood that it doesn't cost that much more to do hypothyroid as well. And there is such a lot more of hypothyroid. So Professor Paul Hoffman, who does a lot of clinics in the Pacific, and Dr. Natasha Heather, who's a pediatric endocrinologist who's been working with us in newborn screening for 10 years or so now, went up and got them started. So we've done 50 or 60 samples already for them.
Mm.
We've also been talking with, there's a Pacific laboratory training in Wellington where and we've been talking to them about how we might be able to support eventually the technology done locally.
Right. Amazing. And the Solomon Islands has been doing a pilot trial on cord blood that Dr. Schuber and Dr. Titus in Solomon Islands has been leading. So there's quite a few countries now starting to do some exciting work. And of course, Indonesia is another country. We're very, very grateful to have one of our young interns doing an internship with Minister Budi at the moment in the Ministry of Health in Indonesia.
He is a star, that one. Absolutely a star. I can share with you that the next Asia Pacific newborn screening meeting will be in Bali.
Yes, great. Well, we're very proud to have Malika based in with the Ministry of Health in Indonesia. She has been asked to help with a report on confirmatory testing, getting to that stage of the newborn screening channel for CAH. So we will reach out to you, Diane, if that's okay, to support with that. So thank you. So moving on, thank you, Diane. Anything else you'd like to say, Diane, or any questions for Diane? Thank you for speaking at short notice and being willing to be thrown into the agenda, Diane. We really appreciate it.
No, but you know, we're here. You know, we've got people in all around the world who, I hesitate to use the word support, but often it's just nice to have somebody else to talk to.
Yeah.
Somebody with some different ideas, somebody who might know some different technologies or know of funding sources, or, you know, so.
Yep. No, that's great. And also, Diane, this issue of 17-OHP, if the CAH community, we will follow up with you as a major action for Chad, Ethiopia, Uganda. Everyone's very keen to talk more about 17-OHP solutions. So we'll follow up with you about that as well.
Cost effective solutions for diagnosis and monitoring. Newborn screening is really difficult to just do with 17-OHP because of the competing steroids that are present in newborn babies. But they're not there in CAH in older children.
Yep.
So a 17-OHP measurement would be easily able to be diagnostic.
Fantastic. And 17-OHP for diagnostic purposes is on the WHO's essential diagnostics list. So again, that fits in very well with our proposal, and perhaps we could have a case study on that for the proposal. Okay, so we now have the team from Colombia, and I would like to hand over to them now to share their story about the incredible work that they're doing for the CAH community of Colombia, but also increasingly connecting with the CAH community of the Americas more generally. So thank you, ladies. We're very grateful and we're excited to be catching your story on video today. So thank you. Over to you. While the ladies get their slides up, I'll encourage you all to look them up on social media because they do wonderful things on social media. And Dr. Paola, did you want to start with some opening words at all?
Angela?
Listo. Bueno, Doc, ¿tú
Okay,
nos ayudas?
sí, voy a presentarlas un momentico. Well, thank you for the opportunity to present our community here today. We are here with Angela, which is the junior leader of the community in Colombia, and her mother, Sandra, who is the leader of the community. And they're going to tell us about the work they have been doing. So thank you very much for this opportunity. So they will speak Spanish and I'll translate what they're saying.
Gracias, Doc. Bueno, entonces, muy buen día para todos. Mi nombre es Sandra Milena García, me acompaña Ángela Nicor Castro, líderes de HSC Uniendo Fuerzas, la primera comunidad de pacientes en Colombia, de pacientes y familias con hiperplasia suprarrenal congénita.
She's saying they are the first community of families living with CAH in Colombia.
Nuestra organización nació en febrero del año 2024 con un propósito muy claro: construir una comunidad sólida, sostenible y con una visión al futuro.
The community was born in February 2024, March 2024, with a clear vision of being very strong, sustainable, and inclusive.
Que
Perdón, no se está
permita,
mostrando las diapositivas, solamente estás en la última diapositiva.
ok, Doc. Dame un segundo. Ya, no. Ok, ya. Perdón. Más que una organización, somos una red de apoyo constituida desde la experiencia, la empatía y el compromiso por todas nuestras familias y pacientes.
More than a community, they are a network of to bring together all the families and to give them support.
La idea es generar impacto a largo plazo.
And the idea is to generate impact in the long term. And this is the story.
Yo quiero contarles brevemente cómo ha sido nuestro recorrido. Todo comenzó en febrero del 2024 cuando decidimos crear este espacio.
Everything began in February 2024 when they decided to create this community.
Lo creamos para empezar a reunir familias y pacientes que muchas veces atravesaban este diagnóstico en soledad.
Because everybody felt very lonely when they had the diagnosis of CAH, and they didn't want anybody to feel lonely.
Meses después creamos nuestra primera red de apoyo a través de nuestro grupo de WhatsApp, lo que nos permitió conectar a cuidadores, pacientes y familias en diferentes regiones de nuestro país.
They created a WhatsApp which permitted all the families to be united and to communicate through WhatsApp.
Durante este año comenzamos a participar en encuentros médicos y científicos mientras realizábamos los primeros encuentros regionales en Bogotá.
Also, they started to participate with the scientific meetings in pediatric endocrinology and also having some meetings with the families.
En 2025 identificamos una gran necesidad dentro de la comunidad. Muchas familias enfrentaban dificultades para acceder a medicamentos o servicios médicos.
The greatest barrier they found it was access to medication and access to medical care.
Así que lanzamos un apoyo jurídico para acompañarlas en estos procesos.
So they found a lawyer within the community that is helping every families to navigate the system and get access to medications and to medical care.
Este año para HCC Uniendo Fuerzas ha sido genial. Continuamos creciendo y participando en congresos científicos, aprendiendo de otras organizaciones y fortaleciendo alianzas.
And throughout 2025, they have been growing and getting to more and more families and getting more and more allies to strengthen the community.
Este mes, en junio de 2026, nuestro equipo hemos realizado nuestro quinto encuentro regional en Medellín, además de lanzar nuestro programa solidario de acceso a medicamentos llamado Toma y Retoma. Y en este momento estamos haciendo nuestro proceso de legalización como fundación en nuestro país.
And in 2026, they have been growing even more. And we went to Medellin, which was the 5th city in Colombia that the community has gone to gather families and to understand their needs. And now they also are getting they're getting I don't know how to say that a constitution as a foundation, a legal foundation in Colombia.
Nuestra misión es seguir creciendo para llegar a muchísimas más familias con nuestro acompañamiento.
And the mission is to continue to grow and get to every family in every corner of Colombia so they don't feel alone.
Queremos construir una comunidad cada vez más fuerte, más sostenible y también más preparada para generar cambios reales para nuestra comunidad de HSC Uniendo Fuerzas.
They want to strengthen the community and get stronger to get a community that is sustainable and that really drives a change for people in Colombia.
Nuestro trabajo se enfoca en 4 pilares fundamentales.
They work in 4 pillars.
El primero es ofrecer educación para que las familias comprendan lo que significa vivir con HSC.
First of all, education, so the families understand what it is to live with the CAH and to have a healthier life.
Porque en el empoderamiento de la educación está el manejo de la misma.
Because they believe empowering families, it's the best for them to have a better quality of life.
El segundo es brindar más apoyo emocional y un apoyo constante en el tiempo.
The second one is psychological and emotional support all the time.
Para eso creamos espacios y rutas de acción que se mantengan.
They have created spaces and pathway so they know how to get this support.
El tercero es trabajar con un mayor acceso a servicios de salud y tratamientos.
The third one is to get access to the health system and treatment.
Y finalmente, lograr que muchas más familias se conecten entre sí gracias a todos los ejercicios académicos y de encuentro que hacemos constantemente.
And the fourth is to get more and more families to be connected, to learn, and to create spaces to connect with them.
De organizaciones muy importantes para nosotros, como la Fundación Siendo.
And we thank Fundación Siendo for all the support.
Porque creemos profundamente en nuestro lema que dice, juntos somos más fuertes.
Because we believe that together we are stronger.
Nuestro impacto. En muy poco tiempo hemos logrado generar un impacto importante dentro de nuestra comunidad.
So our impact is from 0 to 110 families brought together in 2 years.
Pasamos de ser una idea a convertirnos en una red de apoyo que hoy reúne más de 110 familias más un subregistro que tenemos de 300 personas, es decir, el paciente y toda su familia, además de quienes pertenecen a la comunidad directamente, es decir, 300 personas impactadas.
We have grown in only 2 years to bring together 110 families, which are approximately 300 persons because there are many members within each family that participate in the community.
Hemos participado en encuentros científicos nacionales organizados por la ASEP, es decir, la Asociación de Endocrinología Pediátrica aquí en Colombia, en ciudades como Barranquilla y Cali.
We have access to a stand at the National Scientific Meeting from the Colombian Association of Pediatric Endocrinology and do some network with the pediatric endocrinologists around Colombia. So they all get to know that these communities exist. We have been to Cali and Barranquilla, which are two big cities in Colombia.
También hemos realizado encuentros presenciales junto a endocrinólogos pediátricos en Bogotá, Cali, Medellín y Barranquilla.
And we have been to 4 big cities in Colombia, gathering families that we connect through the pediatrics endocrinologists and hospitals in each of these cities. These are the
Cada
4
una de
biggest
estas
cities in Colombia.
Cada una de estas acciones nos ha permitido acercarnos más a las familias, conectar con ellos, en mi caso con los pacientes y mi mamá con las familias, con los cuidadores y construir más confianza dentro de la comunidad.
These encounters have made us bring together the families and to connect with them, with the leader junior and the mother, with all the caregivers, and have a constant communication with them.
Nuestros logros. A lo largo de este proceso hemos construido logros que hoy generan un impacto directo en nuestra comunidad.
In these 2 years, these are our achievements that have a direct impact in the community.
Construimos una red de apoyo nacional que conecta a las familias en distintas ciudades.
We have a national support network that is around many cities in Colombia.
Hemos desarrollado nuestro propio sitio web con información asequible a cualquier persona en cualquier territorio, en el territorio nacional, en todo el territorio nacional.
We have now our website that is available nationwide, and there is a critical information for every family with educational support.
Ofrecemos educación en línea sobre los temas de interés para todos nuestros pacientes y todas nuestras familias relacionadas con la hiperplasia suprarrenal congénita.
We ask the families the topics they want to be educated on, and we give online education for all the families on the topics they have requested.
Tenemos un apoyo psicológico para pacientes y familias que lo necesiten en medio del proceso de vivir con hiperplasia suprarrenal congénita, porque creemos que la parte emocional de nuestras familias y pacientes también es muy importante.
We give them access to psychological counseling. It is available for every family because we strongly believe that the emotional part of living with a CAH needs to be supported.
Creamos un programa que se llama Toma y Retoma, que busca acceder a los medicamentos cuando existen dificultades para obtenerlos.
We have created a program which is a take and retake program. We have medication available for the families. We give it in case of an emergency, and once they get the medication from the government, they have to give it back.
Este programa consiste y lo logramos gracias a la Fundación Siendo y consiste en que el paciente que necesita un medicamento nos llena un formato, nosotros se lo entregamos y cuando la EPS o el sistema de salud lo devuelva, él no lo retoma nuevamente a la comunidad.
We thank the Fundación Siendo, which has given us the bank of medications to have available, and the patient has to fill in a form to get the medication. Meanwhile, the government gives them the medication and then they give it back.
Implementamos el acompañamiento jurídico porque nos dimos cuenta que nuestros pacientes estaban enfrentando grandes barreras en el sistema de salud colombiano.
We have the legal assistance to navigate the Colombian healthcare system because we understood that was a big barrier for many families in Colombia.
Hemos generado alianzas con sociedades científicas nacionales e internacionales que fortalecen nuestro trabajo y nos ayudan a cada vez crecer más como comunidad.
We now have collaboration with national and international scientific societies and other communities, which strengthen our works and make us stronger.
Cuando vemos nuestro trabajo reflejado en números, entendemos cuánto hemos avanzado en tan poco tiempo.
We want to show you in numbers how much we have advanced in 2 years.
Hoy contamos con más de 110 pacientes, familias y profesionales conectados activamente a nuestra comunidad.
Today, we have grown from 0 to 110 patients and families in our community.
Hemos participado en 2 encuentros nacionales junto a especialistas en endocrinología pediátrica.
We have had a stand in 2 national meetings from the Colombian Association of Pediatric Endocrinology.
Y hemos realizado 5 encuentros presenciales en diferentes regiones de nuestro país, enfocados en la educación, acompañamiento y conexión entre familias.
We've had 5 club meetings in Colombia in 2 years in different cities, and that led us to understand what the family needs and to connect these families that had never seen other families living with CAH before.
Y hemos fortalecido nuestra presencia digital, permitiendo que cualquier persona pueda acceder a información confiable sobre HSC desde cualquier lugar y casi en cualquier formato.
And we want to thank Plan because with one of the rounds of Made for Kids, we now have a web and social media presence, and it makes it available for everybody at a national level for all the families, even in the rural areas.
Actualmente seguimos trabajando en diferentes iniciativas que buscan responder a las necesidades reales de toda nuestra comunidad.
And we keep working on everything the community asks for and all the barriers and needs they tell us they want us to work on.
Continuamos brindando un acompañamiento a nuestros pacientes y a nuestras familias día tras día gracias a nuestra red de WhatsApp.
We give support to families and patients 24/7 through the WhatsApp.
Porque es muy importante que ellos no se sientan solos en todo este proceso.
We don't want any family to feel alone, never anymore.
Seguimos desarrollando nuestro plan toma y retoma para facilitar el acceso a medicamentos.
We continue with our take and retake program with medications.
Nuestra red de apoyo psicológico cada vez crece más porque muchas familias se están uniendo a esta red.
The network of counseling and psychological care keeps growing because many families are asking for it.
Frente a la necesidad del acompañamiento jurídico, creamos estrategias que nos ayuden a mantenernos en el tiempo y que tenga mayor accesibilidad para todos nuestros pacientes y familias.
We continue to strengthen our legal support to give this opportunity to all the families.
Mantenemos una actualización de nuestro sitio web como una herramienta de información importante, por eso se actualiza permanentemente.
We keep our website updated with information that is reliable and accessible from anywhere.
Trabajamos constantemente en la educación y la sensibilización, participando de foros, de cursos y diferentes mesas de trabajo sobre enfermedades huérfanas y el manejo del sistema de la salud en nuestro país.
We work on education and awareness raising about CAH with the government, with working groups, and with some other communities as rare disease in Colombia.
Seguimos aprendiendo de la mano de otras fundaciones que llevan más tiempo que nosotros, como la Fundación Siendo, como Clan y como otras organizaciones propias del país.
And we keep learning from other organizations or foundations that have been working for a longer time in Colombia, and also from Clan and Fundación Siendo, which always support us.
Porque estamos convencidas como líderes que
Because we,
realmente,
perdón, dale.
que estamos convencidas como líderes que de nuestro crecimiento también depende el crecimiento de nuestra comunidad.
Because we strongly believe that our growth is with the community and with all the families.
Para finalizar, quiere decir que HSC Uniendo Fuerzas nació de la convicción de que nadie debía enfrentar este camino solo.
And finally, I want to say that this community was born because we strongly believe that nobody should live with CAH and feel lonely.
Nuestro propósito es seguir construyendo una comunidad donde cada paciente en todos los rincones de nuestro país encuentre apoyo, información, acompañamiento y esperanza.
We want to go to every corner of the country and support every family that lives with CAH and give them support and walk with them.
Sabemos que aún queda mucho camino por recorrer, pero estamos convencidos de algo que guía todo nuestro trabajo.
We know there's still much more to do, but we firmly believe that we have gone a way.
Juntos somos más fuertes. Muchas gracias.
Gracias.
And we firmly believe that together we are stronger. Thank you very much.
Wow, what an amazing presentation. I think we are all stronger because of you. So thank you so very much. May I ask a question about newborn screening? Do you find that you're having new babies coming into your community through newborn screening in Colombia?
Yes, absolutely. We began, the law of newborn screening in Colombia was accepted in 2019, but it was not being executed in the country. It started in 2024, and we definitely have seen much more children, at least, arriving to the clinic with a newborn screening, sometimes and most of the times not really being a real one, like it was a false positive
Yep.
or not really read by the doctors in a correct way. But at least we get them to the consultation, to the clinical pediatric endocrinology consultation. And it is very moving to see that these children are getting this opportunity. But yes, maybe not getting to the community yet, but at least we see them in our consultation much more.
That's wonderful.
We still have a lot of work to do and to teach how to read this newborn screening correctly, but we much more like to have false positive and tell them, sorry that you got scared and it is not the diagnosis, than missing the diagnosis. Yeah.
Right. Diane, did you want to make a comment? Is that?
Well, only that there are some labs about like ours that are quite experienced with CAH screening, and we'd be very happy to talk to your laboratory people about cutoffs, because false positives are a big problem in CAH screening, but there are ways to make them less.
Malik is doing a report on that at the moment with the Ministry of Health in Indonesia, so we can be in touch about that as well with your team, Paola. Sounds good.
Great, thank you. Thank you.
Can I also ask, I'm sorry for so many questions. This will be my last question, but
Oh,
the take and retake program that you are doing is just amazing. That's a new program. No one else is doing something like that. Can you tell us
okay.
more about take and retake? Because I think that's a very interesting program that no one else is doing.
Well, yes, it was an idea from Angela and her mother. And they asked us, Fundación Siendo, if we could give them some bank medication to keep. And we gave them some hydrocortisone, 5 milligram, hydrocortisone, 10 milligram, and fludrocortisone. And they have about 5 bottles of medications, and so of each. So when a patient needs the medication, because this is in the health system in Colombia, every patient should get it. But sometimes there are gaps in giving the medication. And as we all know, they cannot pass one day without getting the medication. So if they're having trouble with getting the medication with the health system, well, first they identify what is the problem. They get legal assistance. And if it's not possible to get the medication, they will get one bottle. Until they get the bottle from the medication, they have to fill in forms, and then they give it to the patient. And once they get the medication, they give it back to the take and retake program. So they will always have at least 5 bottles of each. And well, they can go down to 3, but they will get it back. So everyone will get the medication, and we'll pay for the transportation of the medication if they are in an area where they can, in a remote area where they cannot come and get it from themselves.
Wow, that's the first time I've heard a community doing that. We would love to write that up as a case study. That's very, very impressive. And have people used the bank yet? Has it been working?
It has been established like 15 days ago, but let
Oh,
me
yes.
ask Sandra. Que están felices con el programa de Toma y Retoma, que es la primera y única comunidad que han oído que tengan esto, que las felicitan, y que si algún paciente ya ha tenido que utilizar algo del programa Toma y Retoma.
Sí, a eso te iba a preguntar, a ayudarte, Doc. Sí, incluso existen otros papás de la comunidad que nos ayudan a engrosar esa ayuda que nos dio la Fundación Siendo, a tener más medicamentos. Pero la ruta no cesa ahí. El reto también es con el apoyo jurídico lograr que este paciente también reciba su medicamento.
Sí, yo les hablé del apoyo jurídico. Yes, they have had some families already use the take and retake program, but also she was telling me that they have some families that also have given more medication to make the bank even bigger.
Wow. Isn't that wonderful? Well, we would love to write that up as a case study, work with you to write that up. So,
Okay, that
congratulations.
it's a
This is community coming up with ideas. This is just wonderful. Congratulations. So,
thank you.
wonderful. Well, that brings us to the end of our agenda, but I think we all agree that it's been an amazing meeting. Thank you so much to the Colombian team for getting up so early, to Diane for staying up so late. Esther, we've had so many WHO regions involved today. It's been a real honor. We will be sharing a recording of this video with the rest of the Mates for Kids network. We know everyone will be really interested. We can't thank you enough for sharing all of your stories. And to steal the words of the team in Colombia, together we are stronger. I think as a CAH community internationally, we are getting stronger and stronger and stronger. So congratulations to everybody. Well, thank you, everyone. We will send out the video recording and the resources. And Diane sent something that's under embargo for newborn screening, but we'll get that out. All the resources that have been shared. We've got a case study from Tonga that's just fantastic that Natasha Heathers sent with more information. We'll get all that out in the minutes. But until next time, I think our next event where we'll all connect will be Science Summit in September. And the Colombian team will be presenting there as well, which we're excited about. So, all right. Thank you, everybody. Stay well, and thank you for everything that you do.
Thank
Bye.
Thanks,
you.
Kate.
Bye.
Bye. Thanks, everyone. Bye.